So, ladies and gentlemen, we are switching gears a bit for the afternoon part. I think the morning part was, to say the least, stimulating and very lively, and thank you for your participation. We're going to focus right now on healthcare. And it is a privilege to be joined on the panel by thought leaders from ESIP's membership. I will start since I'm next to you. Thomas Faton from CNAM in France, Director General, if I get it correctly, the titles. Dr. Doris Pfeiffer from GKV in Germany. Thank you so much for coming. Nina Nisila from Kela, a huge institution in Finland, and we will hear more about it. Pedro Facon, Deputy Director General from INAMI here in Belgium. And I would say, a special guest from WHO Europe, but a very relevant guest, David Novillo-Ortiz, as I said, from Copenhagen, from WHO Europe. Why? Why is David on this panel? And maybe we can start already with him to give us a bit the context. Of course, you're going to hear from ESIP's members about healthcare and what digitalization means for your institutions on the ground based on your experiences and lessons learned. But WHO Europe, actually last week or 2 weeks ago by now, I've lost track of time, adopted its first digital health action plan at the regional committee meeting in Tel Aviv, Israel. And David, correct me if I'm wrong, but you didn't have a hard time convincing the member states. If you can explain to us a bit, what were the key messages? And if the people, our friends online, if you could please mute yourselves. If you can just mute yourselves and then we can go on. Please, David. So what is this plan and what triggered this action to start with? Thank you.
First of all, thank you so much, Yanis, for inviting WHO to be in this important event and be surrounded for these great colleagues. So 1 week ago, the 53 member states of the WHO European region agreed to move forward in the same direction about digital health. And for me, those are the big news for us, to put together 53 member states in agreement in how to move forward in one specific area of work. And why we're doing this, why we propose. No? Some of you can say, we're in 2022, is there a real need to have a plan on this? So what we have learned, and we're still learning from the COVID-19 pandemic, is that digital solutions have gained credibility to try to respond to the pandemic. That is one thing that I would like to share. Also, we're trying to recover, and we're still working on it, and how to recover for this important crisis. And for us, there is a need for longer-term strategic investments to continue enhancing health systems and services. We have seen how digital solutions can contribute to this, and we are fully committed to work from a data-driven approach to ensure that we can continue supporting countries, but also important countries can support other countries to continue learning in how digital solutions can improve health and well-being across the European region.
David, if you can, just in bullet points, what are the key actions foreseen?
So, first of all, when you're looking at public health areas, communicable diseases, non-communicable diseases, you can already find a lot of evidence, good practices, networks, knowledge exchange. When you're looking at digital solutions, we're still learning. And we are used just to share the positive insights from these experiences and not the negative part. So we are fully committed to continue developing technical guidance to support member states. The second will be to enhance country capacities. Again, as I said at the beginning, we are the secretariat for 53 member states. Not all of them are in the same need, but there are some countries in which we need to strengthen and support them since the very beginning, just to have a governance mechanism. I was fascinated about the big progress that is happening in the European Union along this morning to learn how we are moving together. But when we are looking outside the EU, the reality is quite different. So when I was listening to some of the challenges, of course I was not laughing because I agree with the challenges, but I can assure you that there are more basic challenges across the European region and across at the global level that we still need to work together to move in the same direction. Because if we move in silos, it's going to be impossible to move as one global approach. The third is to continue strengthening knowledge exchange and promoting networking, like something that we are doing here today. Again, we need to continue working together and to share the lesson learned, particularly from the failures. I don't understand why so are terrified to share the failures. We need to say it. And it's fine because others will benefit from that. And that is something that we should continue doing. And finally, something very basic. Look at what is working and try to scale up that at the global level. And that is something that we are still not doing. So that is the overall plan that also the member state has asked us to move forward. And of course, we count on all of you to continue working in the same direction.
Thank you very much. And I think a lot of these resonate with ESIP's members and reflect the needs of member states. And I think that's what you try to do with the Digital Health Action Plan. Dr. Pfeiffer, in Brussels, as we speak, there is a lot of lobbying going on several topics. And here, when we talk about digitalization, it's also about selling about a lot of these technologies. What is your experience in Germany? Should we be cautious, but at the same time curious? What would you say?
The question is, give your answer, like most of the questions the moderator put in the discussion to use a discussion. We are convinced that the digitalization of healthcare and long-term care.
Make sure that this is on. Voila, now it's on.
Okay.
Voila.
Usually you shouldn't touch this. We are convinced that the digitalization of healthcare has high potential for good quality and cost-effective healthcare. In Germany, we have connected service providers and health insurance funds. We have a national digital infrastructure. We have introduced electronic health records and electronic prescriptions. We reimburse digital health apps, one of our main topics today. The EC system is up and running. That has been discussed this morning. Thus, digitalization is part of our core business. However, digitalization is not a magic bullet. Moreover, all that glitters is not gold. And we think that new technologies and methods, especially digital technologies, have to meet the same high standards of evidence-based medicine as traditional treatment. Sometimes it seems that we apply sort of double standards in the interest of industry and supposedly innovative sectors. We think that the interest and well-being of the insured, the patients, and the contribution payers must be at the center of the digital transformation. We as health insurance funds have to safeguard that our resources go to services and products that evidently benefit patients. The EU has definitely a role to play in all this. The HTA has strengthened the role of evidence-based health technology assessment and will contribute to identify real innovations. With the Patients' Right Directive, we have started to connect our healthcare systems EU-wide in order to exchange patient records and prescriptions electronically. We think that the European Health Data Space is an important initiative. 2 points are key for us. Further developing the EU-wide exchange of patient data for cross-border treatment must take into account the systems and solutions that we already have at national level, and making best use of health data for research and policy making must primarily, let's say it again, benefit patients and healthcare systems, not industry.
Very clear. Thank you very much. Very clear points, very clear messages. Pedro Fagon, do you agree? Not everything that glitters is gold. We heard a lot right before the lunch break about the experience also of that Belgium has, the very rich experience in e-government. But specifically, from your perspective, from the perspective of Rizvi and Ami, what would you say on this?
Maybe first of all say that also in Belgium we have a lot of digitalization with regard to financial administrative relationships between actors in healthcare. We also invest in electronic health records, but I'm not that I'm more critical about the maturity of all these things. What we see is, for example, that with regard to financial administrative arrangements, we have come a long way, but with regard to the electronic health records, it's rather in silos that this operates, and really making it a shared electronic health record where different types of providers, but also between ambulatory care and hospital care, there would be real exchange. We're very far from that point, so there's still a lot to do. Then, of course, the third generation of digitalization, if I can put it like that, would be that we use like apps and other types of digital solutions in delivery of care. And there we have seen a lot of opposition, for example, of doctors with regard to teleconsultations. During COVID, we introduced this, but now we have a big discussion if you want to maintain it and under what conditions. And honestly, I think we could do more, and certainly in a context where we have a lack of resources and where digitalization could help us to be more efficient. But this will take time, and we will need to be able to demonstrate that digital care, for example, in a therapeutical relationship that is established between a doctor and a patient, can be equally qualitative like physical contacts. Maybe with regard to the apps, I'm in a double position. I think also my generation, even if I'm growing old too, but we are very convinced that via apps, etc., we could do a lot. So, for example, with this watch, I know so much about my own health, and this is very useful also for my providers to know this, and this is not being used for the moment, or not as it could be. On the other hand, there was a recent article in The Economist. I don't want to make publicity for this journal, but that was very interesting. It was about the mental health care apps in the United States, where there is really an explosion of apps. And you can look at it with double perspective. On the one hand, of course, we are very happy that patients or people who are in difficult positions maybe have access to some care or some support through these apps, but there's also a business model behind this, and often it's also very expensive. And also, when you talk with clinical psychologists, etc., they are very worried about the fact that there is not a lot of quality control on it, and that maybe we lose people in the regular healthcare system. So I'm really in a double position, because on the one hand, I really believe in it, and also I believe in it because of the fact that we have a lack of healthcare providers. On the other hand, just until where do we need to be sure about the quality? We need the same standards, but then, of course, I'm also a little bit critical, because often when we reimburse physical contacts or nomenclature for regular healthcare, there's not always that many evidence either. So we shouldn't be more severe for the digital solutions either. But we didn't find the equilibrium yet of quality and access, safety for these solutions.
So curious and cautious at the same time. Nina Nisila from Kela, a huge institution in Finland. But Nina is very much hands-on when it comes to the IT infrastructure of your institution, if I'm not mistaken.
Yeah.
How does this sound to you? Because you need to come up with your people,
Yeah.
with the technical solutions, and to translate these dilemmas into the digital interventions. Please.
Can I say it out loud? It's pain in the ass. Really. You can't put it more diplomatically, sorry. But I listened to previous panels, and you were mentioning about putting the IT people and lawyers in the same room. Well, I have to say about my background, I've studied international politics, peace and conflict study in university way back. And there's probably a reason why a person with this background is doing business with IT people and lawyers and doctors as well, when we are improving the social security, digitalization, and also also the healthcare business. So yeah, it's it's complicated to be frank, but it should be in certain way. It should be like that, because we are, like in the previous panel, you mentioned that it's very sensitive data. So you have to handle it with care. And if you lose the trust, it's really difficult to gain back. So preferably, even though it sounds a bit crazy, but preferably slightly kind of more cautious and do the right steps and then proceed than be hasty and make serious mistakes. That's my opinion. And a couple of years ago, we had a serious incident in Finland. It was one of the mental health institutes which had a big data leak. And all the information they had around 40,000 customers. All that information was leaked online in dark web. And it was a big thing in Finland. And of course, the end result was that that service provider it went bankrupt. And actually, the information is stored in Kela nowadays because nobody wanted it. But and it was one of our partners when we do the rehabilitation in a mental issue. So we used that service provider previously. So we had this kind of connection with the situation as well. And that was a kind of awakening call in a certain sense in Finland, that you have to be careful. In that case, they didn't have really any data security specialist in that organization, and the CEO did the code that they use in the systems himself. And he didn't even study any IT. He was just a self-learned person. So you can guess the rest. So that's an example of the thing that we have to be really cautious. But the other part is that while we are cautious, we have to still be progressive and try to understand the customer's journey and make that more easy as possible. Anne mentioned about the elderly people, and the one thing is that when you are a certain age, and if you have Alzheimer's or dementia, it will be really difficult to separate your phone and your remote control of your TV, as an example. Nonetheless, if you have to do some business in some web service. So one of the answers is that we should put as much effort to the process automation as possible, so that the things that customer has to do online are as easy as possible and as little as possible. So as much as we have the information, we should be able to use it for the customer's benefit, so that that elderly person doesn't necessarily need to do pretty much anything, and the things will be taken care of. And that's the kind of thing that we are aiming for. But it's a road filled with different kind of difficulties, mostly legal difficulties, like you probably all know. And that's why I occasionally do this kind of a nasty human experience, being this peace and conflict study person, that I put the IT people and the lawyers in the same room and see what's happened there. And but we have some good examples in Finland as well. I tell you my personal experience for the last summer. A couple of days before my summer break, I realized that I have to renew my drug prescription. It's some kind of a medication that I've had years, and I can't abuse it or sell it or anything like that. So it's not any dangerous there. And I was doing my telework at home, and my doctor's place is 30 kilometers away, really difficult to find parking slot or anything like that. So I went to the online service, and I realized that I can do an online chat with that doctor, and or that medical service actually, because I didn't use the regular doctor. That doctor who I chatted with was 1,000 kilometers away. And he had the information of my situation and previous prescriptions, etc. So he saw the whole history. It's actually in Kanta service, which Kela is taking care of. And he just asked, "Are you happy with the medication?" And I was, yeah, okay, I'll write you the prescription. It took like a minute. And then it was there. Immediately it was in the Kanta service. I could check that it was okay. And afternoon I went to the pharmacist and picked up the prescription there without having any papers or anything I just identified myself, of course, so that they knew who I was. And that's when the things are easy. And that's a private-public sector collaboration at its best. But of course, I have other examples, maybe later when it doesn't work that well. But that's one example when it really works well. And even the elderly person would have able to manage that kind of situation, possibly.
Thank you very much. Thank you. And I appreciate that you're bringing real life situations here to the panel, because at the end of the day, what we're talking about is people's lives and how these clients or users or citizens at the end of the day, the insured, will have access and benefit from these services. Thomas Fatom, talking about big institutions, CNAM is pretty sizable, I would say, in France. Where do you see the opportunities, especially for, but also the challenges from your experience, also with an eye on the EU level action and the EU initiatives? What would you like? What is the message that you would like to give? Thank you very much.
Thank you, and thank you for inviting me. Maybe just to start with opportunities that the digital healthcare present. It is quite clear. Promote, of course, access to care. You took the example of remote teleconsultation. Avoid, of course, unnecessary expenses. How to make better health pathways. Also to simplify the daily life of patients and professionals. So that's why we say ambitious, cautious, and ambitious. That's why we are trying to invest quite a lot of money, 2 billion euros for the next 4 years to implement our healthcare digital strategies. So this is quite a big amount of money. And with one or two key points. First, it has already been said, we need to propose patients, our clients, tools that they like, that they enjoy, like private sector can make it. And that's why we decided to launch our individual digital health space, health digital application, and with the idea that we could maybe try to do as good as private sector can propose digital applications. So this is at the same time shared medical record, secure health messaging system also, and I will insist on security stakes, and also a store for all digital application in health systems that we want to reference and to evaluate, to say those are good applications, and we want to propose those applications to our patients. So we launched this.
Is it doable or is it overwhelming as an endeavor? This assessment that also Pedro referred to.
Well, we're building the assessment, the health insurance system, also independent public bodies that will make this evaluation and says, okay, these are applications you can put on the public store. So we launched this product on February, and with also quite a revolution in France based on an opt-out system. People could oppose to create this individual health application, and if they don't oppose, it is automatically created. So at the end of this opt-out period, which is at the end of the summer in September, we have now 60 million people in France who have this single individual health record. It's just the beginning, and I cannot say it is going to work, because this is the second point. You've launched the projects, but you have to convince the patients and the professionals that they have to use these products, and it's good for them, good for their health.
Is it difficult to convince them?
It needs money also, especially to convince the professionals that they need to feel this store, and I mean, this is an investment. I mean, I'm okay with it. I mean, if people from biology, hospitals, you pay them so that they will automatically feel this record, and it is going to. We believe it's going to work, and because we see that there are for example, the hospital in Paris now automatically they feel the record. So this is our big project. We believe it can work, but we are also very modest because we know you have to create value, and for people that they will have the reflex to use it in their everyday life. Just two things to finish with this intervention. I think we have to have rules when you talk about digitalization. It is simple, but because it can be the better, it can be the worse. I was very interested by the example, Nina, you just took about the remote consultation. It's very useful. At the same time, what is the guarantee of the quality of the consultation you have in those circumstances? And we see in France, it is more like the Far West or the jungle. That's health pathway which is built in a good way. We see people doing 1, 2, 3 remote consultation, 4 because they just want to have a sick leave. And at the 4th consultation, they have the sick leave because the doctor says, "Okay, I will give you a 2-week sick leave." So it can be the best, it can be the worst, and so we have to set rules. And we just set a deal with the doctors to say any doctor in France, he cannot make more than 20% of his activity on remote consultation. And we are very criticized with it because people are saying, "Okay, you want to kill." You do not want digital improvement to happen in France. We believe it is good when a doctor sees a patient in the old way in his office. So this is an example. And just to finish, we need rules and we need security. Security is the key item of trust, as you just said. Yes. 2 weeks ago, we had in France a massive cyber attack and a big hospital in France. The hospital was almost completely blocked for a week. And we had a few months ago a very little data leak in our own system, and even a very little sends an awful message for patients. They say if you lose their trust, your ambition is dead. Sorry to use also simple words. So this is a challenge. I think this is very also interesting because we can provide for people many improvements. We know there are areas we will not be able to send doctors. It is clear. So remote consultation can be, of course, for them a very good way to have access to healthcare, but there are many challenges.
Thank you very much. Very helpful and interesting in steering the discussion. And I think everyone is getting inspired. And I'll come to you with your questions. Doris Pfeiffer, me listening to you, you are the thought leaders, the experts from the field. Can you be ahead of the game, or are we running behind the developments? What would your feeling be, especially in terms of these technological developments and what Thomas Fatton just described as real-life risks?
I think we have no choice. We have to go this way. We have to make rules and regulations. That's very important. Just to secure data, we have to make special regulations. We have to make regulations that there's a protocol who looked at this data to have to data protection and so on. We have also, I think we have to offer apps, and I think there's no doubt that we need electronic health records that are shared, that we use telemedicine. But as you mentioned now, we have almost similar discussions in Germany because there's a maximum of 30% for doctors to do consultations by telemedicine. And after the pandemic, after the worst time of pandemic, everyone said, "Well, why is there this maximum?" They never used more than 19%, so it was all of the time it was below. And a few weeks ago, I read that in Sweden there was no limit, and they examined the data of people who use this telemedicine, and they found out that it was almost all of them were young men who didn't go to a doctor. So the question is, isn't there a need for this telemedicine in general, or do we have to offer the opportunity and to regulate this so that we can use that, but don't misuse that and use it by people who don't need a doctor? Thing. So there are a lot of things we have to do. We have to develop. We have big discussions, as I mentioned before, about the digital apps. We have sort of fast track exam. It is they are checked by state institution, but the criteria are far lower than the criteria for, let's say, drugs or so. And so we realized there are a lot of apps for mental diseases, a lot of electronic digital diaries, which cost a lot of money. And they are prescribed by doctors or by the sickness funds. And in the first year, and that's due to our regulation, the pricing is free for the industry. So there come a lot of apps which are examined more or less. They can be prescribed also if they have no full examination. So for 1 year, they are free in pricing, also free in showing their benefit. And this it's a huge market. Up to now, the doctors in Germany are very not so positive in prescribing that. That's our opportunity to just to maximize the costs, but it's a market for digital companies, and they see a big market by selling it to patients and being the costs going to the sickness fund. So.
Thank you. And David, you referred to it also as one of the priorities, the assessment, the need to assess this innovation or so-called innovation or nice to have innovation from meaningful innovation. What will be what will the next steps be?
Thank you, Gianni. So we can see how usually are making developments without having data for these developments, right? So we're a bit obsessed trying to develop monitoring frameworks to support countries in how to measure digital health. Of course, this is challenging because if we are asking today what digital health means to you, we will leave this room with 70 definitions, right? If not more. So we are convinced that having a common understanding in how to monitor and measure digital health will contribute to move forward how proceed with these longer-term investments. And also, it was quite interesting listening to Pedro and the colleagues about the apps and how we can move forward with digital apps to really empower the citizens. And we really believe that we need to invest more in digital literacy, because investing in digital literacy means that we are providing the citizens with the right tools to make the right choices, right? So we also look forward to have something that can endorse the quality of an app. We know how difficult it's going to be that, but in the meantime, we can develop digital literacy solutions that can empower the citizens. Because from our point of view, also one of the main challenges is that we are not putting the people at the center. So if we develop solutions without putting the people at the center, we can see what happened. We can see what has happened with the COVID apps. In some cases, they has been successful, but it would be important to look at why these cases have been successful and why others not. So.
And then, Pedro, some lessons learned from the pandemic and the role of INAMI in terms also the data flows and the health data. I mean, I think we all agree that it is a gold mine, and we will talk about it extensively in the next session in light of the European Health Data Space proposal. But what would you say that your experience, your practical experience, what would you fix? What would you manage differently? What would you, in light also of the pandemic that also David referred to?
What we in Belgium saw with during COVID was that if you will ask providers, individual providers or institutions, they will say that they are overwhelmed by registration obligations, that it's very hard and that we should lower this pressure on them because it costs a lot and it's not going to care. And then again, when we were in crisis management, we saw that all this data that was collected, it came often too late, or it was not the data we needed. So I think that it's still a lot of push registration we have in healthcare. So it's prefixed fluxes of data that providers and insurers need to transfer to public authorities. The big challenge would be if we really whole healthcare sector, providers, public insurers, etc., that we can pull the data that are in electronic health records with individual providers, institutions, insurers, and that we rather can not burden the providers and the institutions and find the data ourselves. So we had a lot of problems with timely data and the right data. So we are very far away from this, really capitalizing on all the data that's being gathered. That's also because we don't collect as a public authority. We don't collect the data. We rather collect them for administrative and financial reasons than for public health reasons. It's maybe a little bit shocking that I say this, but in the end, we are spending billions of euros, and a lot of the data we receive is to somehow create accountability with the spending of these data, but not really with checking on public health objectives, and that's one of the realities we live in. So.
Excellent. Yes, thank you very much. Nina, are you bombarded with data that you don't need? Are you flooded with data that you don't need? Do you have a gatekeeper? Do you have a filter to really make the most of what you get? Because as Pedro said, there is a huge flow of data, but is it all necessary or useful?
Yeah, that's an excellent question, and I'm not absolutely sure. In my Kanta, which is the database of the health record, we are e-health record, which we are maintaining. There's information about 6 million people, and there are only 5.5 million Finns. So you can already start to imagine that what kind of information we have there. And there's almost, I think by the end of this year, there will be around 4 billion documents in that archive, and 1.2 million.
Billion,
yeah, exactly.
I heard correctly.
And there will be around 1.2 million documents per day more. So even now we are talking, there will be lots of things happening. So are they all necessary? I'm not absolutely sure. Most of them most likely are, but the big issue is that we are not using it efficiently enough so far. And there are some legislative issues around that archive as well, so that we actually cannot use. We can collect the information, but we can't use it yet, and that's a stupid situation, to be frank. But in future, my assumption is that maybe how the data is collected in the hospitals and in doctors' appointments, there should be some kind of efficiency leap in future in that area, so that there will be only collected the information that is actually really needed, and not all those kind of things that actually exist already in some record.
This is the final question for me for now, and then I'll turn to the audience and our friends online. Nobody's talking about the EU from you. Well, Doris Pfeiffer mentioned the health data space proposal. Yes, and Thomas, I'll come to you. But Pedro, do you think that there is consistency in the e-health initiatives that you're getting from the EU? Are they really of added value, or what would your message be?
To be honest, it's a bit of a jungle for me, but it's also my own fault. Probably we're very focused on managing our own system in Belgium, and we also had some champions also in public authorities that really were early on with developing digital healthcare. This means that now what's happening at the European level, personally, I find it often very difficult to know all the things that are happening, how we can really participate in it. And the transaction costs are generally quite high. So this is just my point of view. It's not really criticism, but it's something to take into account as a European Commission, that also for member states to be able to follow up and to participate in initiatives, it needs to be clear and coherent. Maybe one thing I'm really convinced that a lot of things could be done at the European level. If we're talking about a digital health infrastructure, a series of standards with regard to identification, authentication, encryption, also the languages that is being used in electronic health records. So we are doing things on SNOMED, on other types of language. These kind of things, it's stupid that we should do it on member state level, and we are doing translations of terminology of all sorts, but this should be something that should be communitarized and being done together. So I'm a believer of joint action. I'm definitely a believer, and in the digital sphere, it's certainly the case. But then it should be also transparent. And as for the apps, if the European Union wants us to participate in it, as for the apps for the patients, it should be a delight to participate in European programs. And today it's rather
Burdensome.
I wouldn't say burden, but I don't find a better word.
Thank you, Pedro. Thomas, you were keen to come in on this, please.
I told you about the store of applications that we are opening and we are referencing, and I was quite badly impressed to see that we have very, very, very interesting applications that, in fact, do not respect GDP, GDPR, the data protection regulation. And I think, as I see that, I was thinking to myself, is it too hard? I'm not sure. And how the market...
Your mic, just your mic is on.
How the market of the European Union, it's a huge market.
C'est allumé.
You mentioned GDPR, it was done.
Yeah. Thank you. It's better. And I was saying to myself, Europe has to help his startups, his young firms to respect this data protection scheme, to protect his sovereignty, but also really to help them, because I mean, if we don't want to see a situation where our patients will have like a lack of chance because they won't have access to database, to applications that are outside Europe, this will be a problem in a few years, and this will be a huge problem. So we are really, I think we are right to be strong on those sovereign issues, but we have to go on, and EU has the responsibility to help business opportunities to grow so that we will have European champions, and it will not be Google. We'll make the database, and the people on our data will be in France, in Europe. But I was, I mean, I see really nice applications, and they simply say it is too hard for us to respect data protection scheme. So this is a challenge, and I think EU can help in the way by building this European health digital space. But this is a challenge also for the EU.
Let's see how that goes. We will talk about it on the next panel. I want to come to the people in the room, our audience. Any questions? This is the opportunity to answer all your key questions on what digitalization of healthcare practically means in many member states. Any questions online, perhaps? No, there's nothing? Okay. Then I have a few more, actually. Sorry, I didn't see you.
Well, I'm not specialized in your business, let's say, but well, you have mentioned more standardization, something like that, in this sort of that, you know. But well, our experience from ESSI, and it was necessary to do that by this way, was that we are trying, we are standardizing everything, because otherwise, if you communicate from one institution to the other one, there's no other way. And this was one of the reasons why it took that much time, because it was first to find some compromise. Welcome to my world, you know. I studied law, but doesn't matter, you know. So it's like that. It's always a heavy talks at home and on the EU level, and then that was the first point. And then nobody was ready to start without having it at least to some level implemented, and that is another cost. So when putting all together, then you go really ahead with more costs and more time for implementation. Just to be realistic, you know, I understand your point. I would have the same. So how do you see that? Does it change your mind, or do you think there's other way? And well, I would be a bit hesitating about using app which is not protected in the proper way. So, and how to do that? There must be some standard, you know. So that's another question. How would you ensure that in that case?
Thank you, Jitka. Very good questions. Pedro, you want to take it first?
So if I understood well, so the question is on how far do we go in standardizing, not to, I can understand that, but if I see that all the countries for the moment, so everybody is doing things with regard to electronic health records, so everyone's doing it. In the same time, we often see that for the moment it's just a sort of infrastructure or a concept, and that we should fill it up with data and with intelligence. So it's the right moment, I think, to decide on what language. For example, SNOMED is like a sort of type of language that can be used in electronic health records. In the hospital sector, they use ICD or other types of, in the imagery, we have LOINC, we have all these different kinds of languages. We should be sure that we use a little bit the same languages, because also when we discuss with industry, and when we want providers of digital solutions to come to the European markets, then it's interesting that they know that it won't have to be adapted to every country, because it's another system. So I think there are still a lot of possibilities to now early on to really set some standards and to start it, because there's not even a debate on it. Secondly, for example, when we have electronic health records, when as a Belgian citizen I go to Spain, I need to be hospitalized, and for example, when they need my data, it should be disencrypted here, it should be transferred, and it need to be encrypted again. All these kind of technical rules could be standardized, and I think that we're not doing enough there, and that we are struggling with the member states on our own. So
could it be done bilaterally? Is that what you're saying?
Of course, but we're doing that. For example, with regard to language, we're working together because we have like 3 languages. We have German and then Dutch and French. And of course, for SNOMED, for example, we need to translate in 3 languages in our country. So we looked at Canada and France, if they already done things, because it's an international language in English, and then it should be done in the national language. So we are working together, but we're losing a lot of track and efficiency doing it bilaterally. I think we should do it. If it's communitarian or intergovernmental, I don't care, but we should do it together.
Thomas, a comment on that, or do you want to give a quick reaction to the question, and then we have another question?
Just to be clear, I mean, I really think that our European regulation and data protection is a treasury. This is something we need to protect. I'm just saying that I see private business private applications that I'm not sure that European solution exists. So they go to Microsoft, they go to Google, and because they say, okay, this is cheaper, this is better, and we this is the way we are working. So if the European market does not manage to give the startup, to give all those young people that have so many good ideas, European tools that respect our protection data, we will have in a few years a problem because this will be done elsewhere. It's just my point. Every day I talk with private sector in those fields, and I say you don't have a choice. You have to respect RGPD in France, GDPR. I would say it in English, but there is no way, no other way. But you have to think in the next few years.
Thank you. We have a question here.
Yes, hello, Claudia Schadl from the Austrian Social Insurance. Thank you for this interesting panel. I have actually more or less two questions. One is the electronic health records, and the other one is when we come then to AI. So it's more, I think, the question to the member states, the colleagues here. Sorry. On one hand, we in Austria, we are already, we are about to implement the electronic prescription system. Technically, we would already be able to have also the electronic health records, but it's somehow we have some obstacles also, especially regarding the doctors. So I think this is maybe a huge problem also for you, because thinking then in a European health data space, you have the electronic health records, patients will have access. So I think also in the next step, the doctors will have to change a bit how they register their diagnosis, thinking that the patients can see what they wrote. So I think this is going to be a huge hurdle, how to also bring them on board. On the other hand, it's also the doctors who are going to or have the obligation to invest also. So how are we stepping in then, or how is society stepping in with this huge investment? And then coming to maybe the AI question is, then we are already talking about some doctors might not be needed anymore, or less needed, like radiologists and pathologists. Let's say, I think we are not yet there, because I read studies that in breast cancer, it's still better to have a doctor. Even two doctors were always better than the AI. So how do we bring them on board? How do we make the system then more efficient? And also for Social Security, how to save money also with this more efficient system, because I think this is also an important question for us. How is it really for both sides, or for all the sides, really useful and a win-win situation? Thank you.
Doris Pfeiffer, you want to take
I don't
one
know
of the two?
which is the right microphone. It worked. There are several questions in that, so I'll try to start. I think that the patient data, we are trying to implement that in Germany too. Trying is the right word for that. The new government now wants to change the regulation so that we have an opt-out system. Now we have the opt-in system. We also have the problem that up to the beginning of this year, doctors were not connected to the system, so they couldn't fill in. That's why the sickness funds did not make much propaganda about the records, because it was not interesting. What was only the administrative data. It's not what was not interesting for the patients and not for the doctors. I think doctors are the main players in that, because they can convince patients that it is a good thing to have such patient record. Our experience is that doctors are convinced by money. So you have to pay them, but it's like that. We have regulations like that. We have to pay for filling the data into the account. That's the main thing. But I will mention also another important factor is the usability of the doctor's software. At least in Germany, the doctor's software is very bad. It's not usable. Doctors always mourn about this software because it's not easy to handle, to put data in it. And there is, at least in Germany, it's a very oligopolistic market. And the software companies don't offer software that is easy to use. And would be one of the main things to give doctors not only opportunity, but also make them use that easily, so that they also convince patients and so on to use the health records. So that is a very important thing.
Doris, we are privileged because we have the doctor's representative in the room, and she will be on the next panel, and therefore she will have of European doctors. She will have the opportunity to reply. Nina briefly and Pedro briefly, because I have one more question and I don't want to miss it.
Sure. So in Finland, we did this e-prescription like maybe 20 years ago, and it wasn't easy. It took time. So it wasn't like over the night and everything changed. In the beginning, they printed out actually the prescriptions, even though that wasn't actually needed, because the data went with the with the digital system. But I think it was more for the doctor, so that he or she actually can give something to the patient. So it was probably more important to the doctor than the patient actually. Nowadays they don't even do the printouts anymore. So it takes time, but it can be done even with the doctors, I can assure you.
Thank you, Pedro.
I join the remark. In Belgium, we have an electronic prescription system, and it was just the same. In the beginning, it was printed with a sort of barcode. Now, with the general practitioners, it works perfectly. We are implementing it in the extramural specialist care and also midwifery, some other sectors that can prescribe. So it's possible to do so. By the way, I wanted to react to something Thomas said. Of course, also myself, I believe in important role of the private sector. But for example, in Belgium, we recently launched with my institution an app of ourselves where you can find the electronic prescriptions that are linked to your name, and you can even order them with a pharmacist of your choice. And this is all done by the public sector. So also the public sector is able to make apps. So
Pedro, what you mean is, yeah, that's good news, because you're essentially saying that you can work together, but you can also dictate based on your needs.
Of course. So for me, there doesn't need to be a competition. We should collaborate. And maybe I really join the point made by my colleague about the user friendliness of the electronic health records for providers. It's really a big issue. Let's not underestimate that. But I can just see that in Belgium, at a certain moment, there were some general practitioners that created their own firm. It was sort of associative firm. They are doing it for 10 years. It's also a catastrophe. So it's rather linked to the complexity of the digital solutions we are looking for. It's the nature of the business we are trying to digitalize that is very complex, and that is not just like a simple bank, if I can say so. With some simple functionalities, we are doing a lot more. But if we really, it's not only about the patients. If you really want digitalization and healthcare being done properly, we will need to make better solutions. And that's something our digital architects in public and private sector really need to work on.
Thank you, Pedro. One final question, and then I'll come to you with concluding remarks, please.
Thank you so much, and thanks for the panel. I work for the Greens at the European Parliament. I have actually one question and one comment for Pedro. For me, that was quite a red flag when you said that it would be ideal to have the data available, and then US insurers are just going to look at what you need, because obviously we always try to push for data minimalization, and also to know that the consumer always knows what their personal data are used for. So that's just a comment. But I have a question to Nina. Maybe if you have a good solutions where, because you mentioned the necessity for user friendliness, and yeah, that's something that we're actually trying to figure out in the data space proposal, how to make it user friendly, when also you as a consumer, you can hide and you know, different information, you have to consent different information. So maybe you have some good practices from Finland to share. Thank you.
Yeah, absolutely. So please be in contact so I can share the information, and I can matchmake you with the right persons as well, because it's this is an important issue that before we make a legislation, we have to understand the kind of possibilities. And if we have good examples, so we could share the information about those as well, so that if we make the legislation, and some cases we actually need that, so it's done in the best possible way and not based on some assumptions and maybe fears.
Yes, absolutely. And talking about legislation, also looking at the European Health Data Space proposal, it is very complex. So I wonder how that is going to be implemented when you have to put legislators, lawyers, and IT people together.
Terrible.
Well, let's see. Let's remain optimistic. But David, I think, and just to do a final round of concluding remarks, I think these are questions that you're getting also from the member states. And one of the priorities of the plan is to enable this mutual learning and the exchange of practices as one of the key priorities, correct?
Yeah, so very briefly. So again, I will repeat what I have been saying. So we are convinced that working together, we can move in the digital health agenda. We need to share the failures that we are having, and not only the things that are working properly. And then that will help us to move forward. We're also planning to develop a strategic partnership council. We are trying to bring the private sector also. That is going to be quite challenging. Of course, we cannot do it together. So we look at our leaders in the European region.
Why is it going to be challenging to bring them on board?
Conflict of interest, how to make clear that we are going to focus on centering the population, and that is going to be our main priority, to ensure that they are protected at all times. So always bringing the private sector for us is quite complicated, as you can imagine. So we are trying to make this right. It's going to take time, but when it's done, I think that everybody will benefit from that effort. Thank you.
Over to you for some. Is it necessarily complicated? Will it be?
All is complex today, but I think that also, for example, for private actors, they are also asking, so they also have an interest to join the table. It's in all sectors. It's in pharmaceutical sector. It's for digital solutions. It's for everything that we, in the end, we need to find the solutions together. So big challenges, and maybe we should. With regard to the theme and the discussion of today, we should understand that with regard to digitalization, we are still at the start of everything. And we sometimes think that we are already a long way, but I think we are still at the start to really make digital society and digital healthcare. So there's a lot of things to do.
Nina, are we at the start?
I think we are in good progress, I would say so. And I will have to say that probably it's going to be challenging, but all the things that really actually makes the difference and matter, they usually are difficult. That's a kind of a basic element in that business. But that's actually what makes work life interesting as well, because I think we are all people who are, and actually probably all the people who are in this room as well, that if work life would be easy, we would be bored. So we get going because things are a little bit tough. And if there's a way, if there's a will, there will be a way. I strongly believe in that.
This optimistic tone. Doris Pfeiffer, do you share that?
Oh yes, that's definitely true. Easy is able to cope with for everyone. So we like to have a complex tasks. I think just to stress this once more, it's very important that the EU wants to establish a European infrastructure and governance for health data. That's very important. I would like to refer to Jitka this morning. She mentioned that there was a strong stress on the cross-border treatment, which is only low proportion of what we are doing in our countries. And so the EU has to take into account that a lot of these regulations that should be implemented for cross-border treatment have also their implications for the systems in general. And this makes a lot of effort and is often not realized on the EU level. That's one of the things I would like to bring in. And I think also for the secondary use of health data, I mentioned before, it's very important to have this data to make health policy planning in all of the countries across the borders in the EU. But the main goal must be the benefit for the patients in the system, and not, I'd like to say that once more, for the industry who wants to use the data to sell their products. So this is one of the main focuses we have to have when we are talking about a European infrastructure. And finally, I'd like to say it's very important just to have a counterweight to the US companies and regulations that otherwise have to be used.
It is a global game, that's for sure. Especially nowadays, we see all the geopolitical dimensions. Thomas Faton, over to you for the concluding remarks.
Yes, just to show my solidarity with my German counterpart, I will confess also we pay doctors to fill shared medical records. So we do it also with euros. So you should not be alone. I'm not sure it's a good practice, but anyway, it's the way to succeed. More seriously, just I wanted to share that as a public authority, our role is also not to forget that there are millions of people who are not at ease with digital tools. It is a common sense, but I think it should not stop us to be ambitious and to propose to so many people that want digital tools. But I can say in France, we have millions of people that are not at ease with digital applications. How we can help them, how we can train them, how we can show them that they can. Also, yes. This is a responsibility. If we don't do it, we have the gap growing between people in, people out, and it's not going to be a good news. So
yes, thank you very much for highlighting that. That has been a theme from the start of the day. So you are fully in line with what has already been discussed. Thomas Faton, Doris Pfeiffer, Nina Nishla, Pedro Facon, David Novillo Ortiz, thank you so much for joining us here today. I hope it was an interesting conversation. We move on now to the very juicy part for us Brussels EU nerds, if I can put it this way, the European Health Data Space proposal, which is a regulation. So it's a very heavy piece of legislation. It's not going to be easy. Let's take a 5-minute bio break, and so we can also rearrange a bit the stage. Thank you so much. Thank you for your time. This is the final panel of the day. There have already been references to this discussion that we're about to have on this, I would say, very important proposal that came out from the European Commission recently over the summer on this regulation, which means that it is binding for member states. So it is a pretty big deal. And it is only the beginning, actually, because there will be 9 of those acts. And for some inexplicable reason, no, actually, Martin, you will tell us, the Commission chose to start with the most complicated and sensitive area, which is health. And I'm joined today here by Martin Dorazil from DG Santé, so from the Health Directorate of the European Commission, acting head of unit. Sara Dadas, she's the Secretary General for the Standing Committee of European Doctors, so essentially the voice of doctors in Brussels. Thank you so much for being here with us today. Hubert from Austria, you will explain, Hubert, exactly your constituency, just that I don't get it wrong. And Teresa, let me get the full name, Teresa Cardozo Ribeiro, exactly, from ZIN, from the Netherlands. Thank you for joining us, Teresa. Hello. It's a pleasure to have you, and I hope you can hear us and see us well. Very well. Martin, I'll start. I already asked my question, and it is a genuine question. What was the Commission thinking? What triggered you, and how did you chose to embark on this super sensitive file? Please, go ahead.
Okay, good afternoon, everybody. So I jump directly to the answer to the very pertinent question. You already, mentioned that this is part of the wider Commission's data strategy. So it's part of the larger work on the data spaces in different sectors. I wouldn't say that it was a decision to start with health. Simply, I mean, there's a work ongoing in parallel in different sectors, but we were probably the most efficient one, so we came out with the first proposal. No, it's partly it follows the planned work. So the discussion started, I mean, a few years ago on how the considerations were how to best facilitate the access to data for primary use of data, so directly for the purposes of providing healthcare to individual patients, but also, and that's probably the even more novel part of the proposal, how to facilitate the access to data for the secondary purposes, so for reuse of data for purposes of research, innovation, but also for regulatory purposes or decision making.
That is the most sensitive one, or the most complicated one, if I may say.
It is probably a little bit more complex because it's completely new. I mean, it's the new era. But of course, the work then was accelerated much more by the COVID pandemics, which showed how important it is to have timely access to data, especially for public bodies and the health policymakers to take informed decisions at the right time. So I think this is why the work accelerated now, and why the European health data space is the first one of all the other sectoral proposals.
Teresa, can I bring you in? You can hear us. We see you very well. What are your preliminary thoughts? Because ZIN is quite ahead in the game in the Netherlands, and you take part in the data flows management in your country, and you are experimenting with different solutions, for instance, a sandbox. If you can tell us a bit what you're thinking and what you're actually doing in the Netherlands with ZIN.
Yes, thank you for this invitation to do that. And also to say that I think this legal framework that's being adopted will help us, hopefully, to not only create a legal framework, but that it will also facilitate a learning space for sharing data, but also sharing the examples that was also mentioned in the former panel. I think that that's one of the initiatives that we have started in the Netherlands, because we notice, like others, also have this problem with the upscaling of innovation. So we are having a lot of pilots, a lot of interesting experiments, but the real digital transformation is the next thing to do. So the only way that we can start learning how to transform is by facilitating this exchange of data, starting structural monitoring of the impact of all these experiments that we have. For instance, we have no structural funding of innovations that have data and technology in it. So we have a lot of elements that are not bringing together what's needed for this transformation. So hopefully, with this legal framework, it will improve the urgency within our countries.
Thank you very much. Thank you, Teresa. And can I bring in, because this proposal, if we get it right, and if we strike the right balance, it's about bringing together and making it operational for all the different actors. And of course, there was already the discussion before, one of the key players, obviously, for the success or failure of this and many other proposals will be the role of the doctors. Sarah, what are your thoughts? I know that you're following, and you've been following this proposal before it even left the Commission building. So what are your thoughts now that it's out? Anything that took you really by surprise, or disappointed you, or made you happy?
Better? Yes. Okay. First of all, also from my side, thank you very much for inviting me, and I was following the previous discussion with great interest. Yes, first of all, maybe good news for the Commission. We welcome this proposal. We think it holds a lot of potential to really improve some of the problems also we now saw during the pandemic, and also, as we were saying, give some structure and maybe some support to those member states which have, for various reasons, been struggling to establish health data space at national level, or to really find a structure for this. We understand this is going to very heavily rely on national level data, and then by extension also very heavily rely on doctors in terms of their role in the healthcare provision process. Here, however, yes, one of our first caveats with which we always enter the discussion is that doctors should remain as providers of patient care. So we don't see this now as a tool which will now switch doctors to data inputters, and it should not become this. And I was following with great interest the discussion previously of how to entice doctors into actually providing data to systems. And we do agree that doctors will to some extent be also responsible for quality of data input. But we need to keep this in a reasonable burden. Data and sort of administrative tasks already take up a lot of time of doctors' working time, to the detriment then of time that can be spent with patients. So there needs to be a reasonable balance of this. We also already discussed compensating doctors for this, but we think this is an important point, not only for the time spent inputting data, but also for the technologies that need to be used to build these connections. Also for training, we discussed digital competences are a big issue also on our agenda. And here also we realize that there is also a big role to play for doctors, but again, it must be also recognized by the system. Maybe overall, we see in this proposal much opportunity, but we also see some issues where there has to be some clarification, maybe within the proposal, and also there needs to be some degree of discussion around implementation. So first of all, the principles that were also discussed here was that obviously there cannot be any conflicts with medical ethics, there cannot be any conflicts with other EU laws relating to data, especially we already mentioned the previous panel, the data protection regulation. So these are things where we really see this has to be clarified within the proposal. And then we have many questions about how this is going to interact with national systems when it comes to the interface of electronic health records. We've also had discussions right at the end of the previous panel was the discussion of what happens with personal notes, for example. So this is something that needs to be clarified. Also, how this will interact with national systems, which we understand will still remain in place, as, for example, in regard to accessing health data for secondary use. What is the role of ethics committees? We believe ethics committees should always be involved when it comes to accessing data for secondary use. How do we deal with these opt-in, opt-out systems at national level? So all of these things, we still believe that there is some scope for clarification. Maybe just to pick up on one word that appeared previously a lot is trust, and I think this is something which is very important for doctors for the uptake of the new processes that will have to be there. It helps if they're integrated into normal workflows, but it also helps if there is really confidence in the, let's say, security aspects of the new systems. And one thing that was a little bit following one idea we've had for some time is that most people involved in the healthcare system have great ethical responsibilities and obligations, but actually the IT world is coming new into this. So we believe that there is also an argument to say that IT professionals should also belong to some sort of professional bodies or adhere to professional codes which enshrine obligations in terms of confidentiality, trust, etc., to kind of also increase trust by all other actors in the system.
Thank you, Sarah. I mean, we just heard at least 10 different points that you would like to see clarified, and this is only the beginning. Hubert, from your perspective, because you come from a very practical and operational perspective, so perhaps the European health data space proposal in Brussels sounds a bit distant for you, but what would from your practical experience working in Austria, working with social insurances, what is your message as to how to make this bridge and build this bridge between also what we said, what could be the infrastructure, but what you want to what your objectives are in setting up such an important infrastructure?
So to be honest, it's a little bit far from my profession, right. What I heard they say. I'm CEO of ITSV, as a subsidiary of all Austrian social securities, from pension prevention to healthcare. And we run, for example, the electronic health record, we run the vaccination pass, the green pass, things like that, and all the systems in the social security. So we are with the hands-on developers, and we run the systems as well. So from my perspective, it is very important that that we get an European regulation to this topic, to this European health data space, so that in the countries there are no excuses, let me tell it this way, not to go forward with the digitalization and innovation in healthcare systems. So this is at the moment with all the ideas that come up. We face hurdles in legal interpretation. Interpretation. Yeah. So we can't do that. Why? We can't do that because of, and that's why I was so impressed what Italy did in the pandemic, so that they had immediately the chance to change this. Perhaps I can tell us on an example how important it is to link data. At the beginning of the pandemic, we tried to find out the vulnerable groups of people who are the most vulnerable groups. So it took us more than 2 months to get the legislation and then to link data to find out because of the prescriptions, who are these people who are really in danger with this COVID. So it took us more than 2 months, and this is horrible. If we could have data in advance or much earlier, so we could have had a better prediction and a better location of people who are really in danger. So for us, it is very important that this regulation comes up very, very quick. As you told as well, there are some questions opened. What about opt-out legislation or topics? What about secondary use, and who will profit from this secondary use of data? Is the Social Security only data sponsor, or is there also a revenue or a business case that affects all the stakeholders and things like that? So these things have to be discussed. But at the end, for us in IT, it is relevant that we get such a regulation to be safe in the things we do.
Then it's nice to also have your take, as we did before with Nina Nishlin on the previous panel. Martin, I hear in Brussels right now the member states are discussing the proposal. There are a lot of questions for clarification, and there is also criticism that this proposal foresees too many or disproportionately many requirements on the member states and not so many on other data holders. How would you reply to that? In other words, that most of the work has to be done by the public authorities as opposed to other data actors.
Thank you. Before I go directly to this question, maybe I'll also a little bit comment on what the other speakers mentioned, because the European health data space, it is not only the regulation, it's not only the legal framework, it's much more than that needs to be done before the European health data space becomes a reality. I think it's important to bear this in mind. I mean, I've heard, the comments about the legal uncertainty, different rules being applied in the different member states, and that's the reason why we are putting forward the regulation, to provide a clear legal framework. But that in itself will not be enough. It will not make sure that that there is easy access. In addition, we need to have at least 3 other things in place. One is the appropriate technical infrastructure, especially if we are talking about the cross-border exchanges of health data. We need also have agreed and implemented interoperability requirements in the area of technical interoperability, but also semantic interoperability, so that the data that are being inputted, can be read also on the other side of the EU or within the same member state. And we see the examples that even 2 hospitals within the same country are not able to exchange the data because the systems do not communicate with each other, and incompatible. And finally, and that was also mentioned in the previous sessions, we need to support the capacity building in the member states, training of the staff and the personnel that will be using these opportunities that will be provided by the European health data space. Support, digital literacy also of the user and so on. And all these things are being in place, then the European health data space will become a reality. So besides the legal framework, we are also supporting the member states. And now I'm coming to the answer to your question. We are providing support to the member states on all these other points, especially in the form of funding support. So there is an important part of the European funding that is allocated for the implementation of the European Health Data Space, for the cross-border infrastructure, for the work on the semantic interoperability and technical interoperability and quality of data, and also to support the capacity building in the member states. So now more specifically to your question, yes, the regulation sets out certain obligations for the member states, but we are ready from the Commission side to support them in these efforts financially, but also in terms of organization support and other types of support, so that the European Health Data Space is implemented quickly. Because as we have heard, time is also of essence, and as we saw during the COVID pandemics, the sooner we have it in place, the better for the European patients.
Good luck with that, because it's not going to be very easy to get it through the council. Teresa, we've seen also other attempts, for instance, the medical devices regulation and other attempts where in the end we end up with something which is not very operational. And I will ask also Sarada if this is one of your concerns looking down the road, of course. But we heard also before in the earlier discussion that the question is not the data. We have a lot of data, but sometimes the use of data is poor. Do you agree with this? And is the concern that we may end up with a regulation that doesn't really work on the ground? Is that an issue? Please, over to you, Teresa.
Yes, thank you. Yeah, I know that I should be frowning because I'm a health authority, but our experience is that innovators in healthcare in the Netherlands are often doctors. So these are people on the ground looking for support. They are positively motivated to use data and technology, but are also slightly frustrated because they are alone in this innovation. So I think that if we can make a good connection between those innovators on the ground, really using the data that they collect from the primary process and into the advice for research, for innovation in upscale mode, and also policy, that I think this has a chance to have a new impact that we don't have at the moment.
Can I please ask you to define who are the innovators in your eyes? It would be interesting to have the scope, the broad scope.
Yeah, so at this moment we have this conjoint initiative from the healthcare authorities and the Ministry of Health in the Netherlands. We call it the Digital Health Sandbox, because we have all these barriers to start using on a national scale data and also technology. And the people that we support, we asked, please tell us, innovators, what kind of help do you need from the national government? And our innovators are doctors, individual ones. Sometimes are even collaborating hospitals. Sometimes it's a private company with a certain application that is developed in their labs of innovation. It's diverse.
Yes, thank you. That's helpful. It's a refresher. It's a reminder to know, and that we are looking at this broad spectrum. Sarada, is it a concern that we may end up with something that doesn't work on the ground, or is too complex that nobody can implement it?
I agree with you. That would be the worst case scenario if all of this effort is introduced, and then also all of the actors in the healthcare system, also from the side of Social Security, adapt to these new systems, and then we end up with data that is not usable, or where we still run into similar problems as now. I think to address that, we just need a very collaborative process now, when it's really about finding solutions within the regulation to really make it workable. And I think I've seen many stakeholder discussions already around Brussels on this. I think there's genuine interest if people are trying to make this work. So that is our ambition, and at least from the side of doctors, as I said, we hope this can be achieved.
I want to go to a topic that we've touched upon throughout the day, the question of data protection. Martin, I want to challenge you a bit. This is a proposal, the European Data Protection Supervisor, the protection, joint opinion that came out from these bodies, which are like the European Ombudsman. Essentially, these are independent authorities that are tasked with coming up with an assessment of this proposal. And these independent authorities, I think we have a representative in the room. Thank you for joining us. Came up with an opinion. I'm not an expert on the technical details, but it's very straightforward. It says that essentially the proposal that you proposed comes up with a lot of derogations to the point where you are with the new the health data space proposal. You, the Commission, you are asking for derogations from the existing GDPR legislation. If you could explain that to us a bit, because I think this is something that there will be a lot of questions in the European Parliament. There are going to be a lot of questions also in the Council, in the negotiations. How is that possible, even?
Yeah. Is it working? Yeah, it's on. Yeah, no, thank you for the question. I wouldn't say the derogation is the right word to be used here. And I will try to explain what we are doing with the European Health Data Space. We are not touching the rights that are recognized by the GDPR, and that these rights will remain in place and can be relied on. What we are doing is essentially two things. Some of the rights for the data subjects or the European citizens more generally, with regard to their health data, we are strengthening. So we are providing them with better means how to control and better control and decide on the access to their health data. So we are going, if you wish, beyond the GDPR in a sense that we are providing stronger rights with regard to the health data. And secondly, we are providing technical or very specific means how to exercise these rights in practice. So this is something that the GDPR cannot do, because GDPR is a horizontal instrument, not a sector specific. So we are going much more into detail and provide detailed measures on how, for example, the right to control the access to data can be exercised with regard to the electronic health records or electronic health data in general. So we are not derogating from the GDPR. We are complementing. What the joint opinion of the DPB and EDPFs requested is that there is, this is even further clarified how those two instruments on certain specific aspects, they didn't challenge the proposal as such, but on certain aspects they asked for more clarity how those two legal instruments, interplay and that possibly can be done now in cooperation with the Council.
So you're confident that you will be able to address these serious concerns expressed by these two independent bodies?
Well, first of all, I mean, the proposal from the Commission is now in the hands of the Council and the Parliament. So the opinion is addressed primarily to them. But I think, as I said, I don't read the opinion as fundamentally challenging the whole concept of the European Health Data Space, but asking for targeted, specific clarification on specific issues. And I think this can be done in the legislative process.
Teresa, do you agree? Is that an issue? Is that a concern? Do you see there an inconsistency or a contradiction? And also Sarada, for you as well, and comment on this. Please, Teresa, go first.
Yeah, I think that the digital agenda that the EU is promoting is really acknowledging what's already happening in a lot of other sectors. And I'm happy that in health that we are getting some boundaries, some frameworks clear, because we also talked about, for instance, citizens and their digital literacy. But private companies are having no trouble harvesting their data. So there is a lot going on already. And by acknowledging it and trying to see what is needed in regulation and also learning process as a public sphere, I think that we need to start, because we should already have done it.
Comment on this?
I very much agree. Also from our side, we also, based on the EDPS opinion, saw that there are conflicts in the proposal with, well, we believe the GDPR, but also on with medical confidentiality, with patient confidentiality. So we need to address these issues, and I understand it's out of the hands of the Commission, but I do hope that the Commission will be supporting the other institutions in finding solutions here, because giving any kind of message that the EHDS is slipping below existing standards is really terrible. So we have to avoid that any kind of doubts, even in this direction, appear, and have to make sure that the negotiations find a solution on this.
Yes, because it's also the question of the national framework. And Hubert, please come in. I wanted to bring you in on this.
Yeah, thank you so much. I think we have to pay attention that the market doesn't overtake us on the left and on the right hand side. Like Teresa said, there is a lot going on in the market. We know that a day approximately 200 new apps appear in the app stores related to healthcare. So, and if we talk to the doctors, they say, I don't know which one can I recommend to my patient. They ask me, can I use this app, that app, that? So the market is there. And as Teresa said, they are collecting data because they have the rules that you just click in and everything is fine. So I think we have to be to some extent pragmatic in thinking about how to realize this regulation, so that we in the public sector, with the public responsibility, with the ethics, with European ethics and standards, can provide, well, how to say, a better acceptance with our approach to create electronic health records, electronic or apps, healthcare apps and things like that. So this is a very narrow path we are in, but the market is there and it's running and it's terribly fast running. So I think we have to be very careful that we stay in control as public authorities how to handle this healthcare market. If we don't, we see it in Asia and in US, the systems are completely disconnected to the public influence, or are completely tied to the public influence. And this, I think, this is not the way we want to do in Europe. So we need this regulation quick, better today than tomorrow.
Thank you. That's a very clear message. I don't know if there are any questions in the room or any Teresa, sorry, you have your hand up. So please go ahead, and then I can bring the questions in from the people here.
Yes, I just want to give another example, a little bit embarrassed, but our Minister of Health, for instance, announced Faxit last week. I don't know if you've seen it on the news, but he has prohibited the use of fax machines in healthcare for the exchange of information. I mean, do you remember what that is? So it's being prohibited in 2022 because sometimes it's the only way to exchange. While, as my colleague from Austria mentioned, the public or the private sector has no trouble implementing all kinds of apps for the exchange. So it's really needed that we go to a next step to facilitate real change within the healthcare sector. But I agree with Sarada, it needs to be based on important values of privacy, of respect for the doctor's code.
Yes, and not only of the doctors. I think,
I started by saying that
there's
there's echo.
I was saying that this is only the first act of 9 more to follow. So if we don't get this right, then we will have serious issues across the board. And the last act, if I'm not mistaken, is supposed to be on public administration. So it really affects all of us in the room. I see a question there. And if there's anyone else, please raise your hand.
Yes, hello, Claudia. Charlotte again from the Austrian Social Insurance. So even if I might repeat myself, because some of you already heard it yesterday in the Healthcare Committee, I'm sorry already in advance. I think first question, and I hope it's a short question also to you, Martin Dorazil from the Commission. There is some uncertainty as to the social security sector of how we are involved or of how you see us as a data holder in the entire proposal. I fear a bit that all the, especially the process stakeholders and the actors, we all want to be data users but no data holders. So we are trying all to opt out of this option. But there is still this uncertainty also for us. What are we in the end? And I think, as also some of you already said, I think this is the moment, and for us, it's crucial to be part of this now, to shape this regulation, to bring our opinion, to make us heard, because I think we have to get it right, and we shouldn't leave the entire field to industry because they are present in process, they are active. I think we should work way more together to really cooperate and to make something really constructive. So as we from the Austrian Social Insurance, I'm sorry to do my own compliments, we already are there, we have amendments, so we are trying to be active and trying to be involved. I think we're going to publish them soon, but happy of maybe also having an exchange, but I think this is our moment. I think we have to really give our opinion because we are an important player in this entire field. Thank you.
Thank you very much. And Claudia is right in saying that for us also this discussion today is very important as we are debating and considering our own position on this as ESIP. So Martin, how do you see us? How do you consider us?
Yeah, no, thank you for the question. I understand the question, well, the first question about the status of the health, social security or social insurance institutions in the context of the secondary use of data. Because as I explained, the primary use of data is a little bit more specific. Now, for the secondary use of data, clearly also the administrative data related to social security are within the scope of the data that will be exchanged through the European health data space. So with regard to the users, the European health data space is open to any entity. So anyone can submit an application and request access to data. And then if the application is positively assessed by the health data access body, if it is for legitimate reasons that are set out in the regulation, if all the privacy safeguards are in place, if there are reassurances about the secure processing of the data, then the permit is issued and the data user can access the data that they need. So even to social insurance institutions, there is no restriction from them requesting access to data. With regard to their status as data holders, I don't know whether I said, I'm glad to say, or I'm afraid I need to say yes, they will fall within the definition of the data holders with regard to the administrative data related to health. So there might be requests coming to the social insurance institutions for specific types of data that will need to be channeled through the health data access bodies. For the second question, if I still may, on the kind of involvement of various stakeholders in shaping up the proposal. We had a public consultation as part of the preparatory work on the proposal that is closed now. During the summer, there was also a period where the proposal is submitted for a public feedback on the proposal itself. This period is also over, so we are now analyzing the responses that we received. But also now throughout the process of basically finalizing the proposal with the other institutions, of course, we are open to dialogue with all the stakeholders, including social.
There is in general a sense of rush, though. I feel it. There is a bit of a rush going through. I don't even know how this proposal made it through the intra-service consultation, but there is political pressure, I feel.
Well,
coming maybe from above.
Yeah.
I don't know from where.
Okay, I don't want to monopolize these. I want to give the opportunity also to the other speakers. But on this point, the European health data space was actually announced when this commission started back in 2019. So it is in the mission letter of Commissioner Kyriakides, and one of the important tasks that she should deliver during her mandate. So it's not a completely new thing. And yes, I mean there is a pressure to deliver on this because we promised that we will do it.
Thank you, Martin, for giving me this textbook answer. We have Claudia wants to follow up, and Anna here. See, please, Claudia.
As an add-on, since I'm now 9.5 years in Brussels, we brought our position in and at every possible stage of the process, and we will continue to do so. So, I think also what I missed a bit during in the proposal is, and maybe you have talked about it, or maybe you can elaborate a bit more, public return on investment. So, how do you make sure that not only one stakeholder is generating value, generating money with it, because so far it's not really, in my opinion, really present in the proposal, in the text. So how to make sure that not only industry is using then our data, we are transforming, we are pseudonymizing, we are anonymizing, we are sharing it. They're using it to make products safer and more efficient. And then we are paying again. So it's a certain kind of double payment. And I'm just saying real world data. I think this is the most important term, especially in the healthcare sector. So how to make this sure that it's going to be the right direction and not a one-way street.
Crystal clear. Thank you. I'll bring one more question that I saw. Martin, you can breathe in the meantime, and then I'll come back.
Thank you so much. It's Anna from the Greens. I have also a question for Martin. When in the chapter 3, when you decided to go for self-certification of those EHR systems, so what led to that decision? Like, what would be a difference if we try to be a bit more ambitious at the Parliament side and go for conformity assessments right away from the offset, not after 5 years of evaluation? And also, what do you think about the sort of use of the wellness apps as a source of data, if you think that maybe would be more problematic in terms of data bias rather than gaining the quality? And just to react on the question before, you had while you're covering return on investment, you maybe can also think about the environmental impact of this text and the energy spending. Yes, so now the electronic health records systems should be basically marketed based on self-certifications of those developers of those systems, whereas, for instance, for medical devices, we have the notified bodies that are doing independent assessment. And so we were thinking if it shouldn't be the same way as we do with medical devices.
Yes. So Martin, and then I'll bring in all the panelists to wrap up slowly. But return on investment, is this even on your radar?
I think it is a very good question and a legitimate question. I am just not sure that this regulation is the right instrument to provide all the answers to that question, and I will explain that. I mean, what this regulation is aiming to do, the main objective is make it possible to access the data for the reasons that are explicitly listed in the regulation. And these purposes of processing are generally, I mean, something that will bring public good. So it cannot be just anything. I mean, the applicant cannot just say, I want to do this because I want to make profit. They need to link it, for example, to the enhancement in the area of public health or social security. But there needs to be an element of public good. So we, with this proposal, we will make this possible. I mean, to have the access to data now, and perhaps bring more innovation and advancement in research. Now, the question is how this could be, for example, reflected in the final price of the product and in the level of the reimbursement of the services or products that are provided. It goes outside of the scope of this proposal. Probably, I mean, this should be somehow.
It is a legitimate question, though.
It is a legitimate question, and we are already creating, possible, intermediary steps for that. Because, for example, what the proposal says that as soon as the EHDS was used, I mean, for getting access to data, this needs to be acknowledged in the final product, in the final results. Mm-hmm. So later on in the process of pricing and reimbursement decisions, or even during the health technology assessment decisions, this will be transparent. I mean, it will be known that the company or the provider of the service or the product use the European health data space. And it can be possibly reflected later on in the pricing and reimbursement decisions or in other decisions. But but this goes outside of the scope of this proposal. We cannot solve all the issues within this proposal. The proposal is complex enough already. On the other three questions,
Courage, we're almost there.
So on the electronic health record systems, I mean, just one sentence, just also, I mean, a little bit to explain what we are doing. I mean, we're trying to provide level playing field for all the providers that before they place a new electronic health record system on the market, they follow the agreed standards and requirements at the European level. Now, the question was, we are doing this through self-certification, at least for the first 5 years, and we are not following the model, for example, that is in place in the medical devices field, where there are notified bodies assessing it. Here we try to strike really the right balance, and there is a fine line between providing the right assurances on one hand, and on the other hand, imposing very high burden on the providers, but also on the member states, because I mean the member states will be those that will need to create the whole infrastructure for the assessments of conformity and so on. So this is why in this proposal, I mean, weighing all the costs and benefits and pros and cons, we decided that initially there will be a self-certification scheme, but there is an explicit provision saying that after 5 years the system will be evaluated, and especially, I mean, target the question whether we should move rather towards the certification or assessment done by third parties or not. On the wellness applications, very briefly, I mean, we believe that nowadays, I mean, the wellness applications can be sources of very important and very relevant health-related data for certain projects or in certain areas. There is certainly some work to be done on the quality of data, for example, and on wellness apps, but this is part of the long-term plan and of the four strands that I mentioned. So this will improve over time. I mean, we are quite confident about that. And finally, about the overall impact, including the environmental impact of the proposal. I mean, this is explained in our impact assessment that we have done, and we believe that important savings will be made, for example, by avoiding duplication of different procedures in the hospitals need to, or avoiding the need to do, for example, repeat certain tests just because one hospital doesn't have access to the test results that were done in another hospital, and so on. So overall, the benefits of this European health data space should by far exceed the initial costs and investment.
Thank you very much, Martin. Thank you for bearing with all these questions. Teresa, there are many. We talked about a lot of different subjects, so feel free to comment on any of those, and also so we can also wrap up, and then I'll go to the panel. Teresa, over to you, please. If you can unmute yourself, because we don't hear you.
Yes, thank you. There was a comment on the assessment of the quality of applications, and that there are mandated bodies for that. I think that I should mention also from one of our tasks as the National Institute for Healthcare in the Netherlands, is that the process that we have set in place are really need amendment if it comes to the assessment of technology, because assessing all kinds of e-health, digital health applications is something very different from assessing medicine or even medical devices. I think that we are not distinguishing enough between medical devices and all kinds of applications and technology being used by citizens themselves, also as a part of the healthcare process. And sometimes we are seeing everything as a medical device, and we have very strict, and I'm happy with that, procedures to test these applications. But often innovation and the use of technology and data is just an innovation of the healthcare process. And I think that we don't have an assessment for that. So we are doing clinical trials on things that we shouldn't be doing, I think, but that's the story. Yeah.
Hubert, over to you. Based on what you've heard, essentially on the point also of assessing the innovative value of these interventions.
Yeah, for sure. To link to the previous panel as well. I think what we need is committed standards to assess these applications. And what we need is a clear regulation so that we can gain trust in the applications that are coming up in the context of healthcare, so that we can roll them out within Europe and then start with the data flow within Europe. So these are, from my point of view, three very, very central points of view: standards, regulations, and the assessment, so that the trust in the population is given, so that we can start with this data flow over the borders within Europe.
Thank you. And Sarada, final remarks from your side?
Just that it's been a very interesting discussion. I think it shows the different, let's say, problems the proposal is trying to solve, but also the different complexities that then arise if we go into, on the one hand, data, on the other hand, apps, then also makes a foray into telemedicine at one point. So it's really a very complicated proposal, and I think it is good to take time. I know the Commission has a very ambitious timeline for this, but I think it is worthwhile taking time. From point of view of European doctors, I can say that we're happy to join that journey, but that the best way to get everyone on board is, I think, to make sure that we can say it is safe, it complies to medical ethics, it does not contribute to discrimination in any way or unequal access to healthcare, which we're trying to improve very much in a number of different ways, and that if there is technical and legal clarification, I see that this can be successful.
Martin, anything from your side? Although you said a lot, but as a message, I think this is only the beginning. This is only the beginning in real life, the beginning in the co-legislative process, with the negotiations in the Council, with the Parliament. So we hope to contribute to this conversation. But please, your message.
Yeah, I would like just to emphasize what I said. I mean, the legal proposal, I mean, it's just part of the journey. It's just the start of the journey. There are many other things that will need to happen to make the European health data space a reality. But it needs to be a joint effort with the member states, but with all the stakeholders. And we truly believe that once the European health data space is in place, I mean, it will provide important benefits to everybody, so to the citizens, but also healthcare systems in the member states.
Thank you very much. Thank you very much for joining us. Thank you, Teresa, for being online. It was a pleasure. This is only, as I said, within ESIP, we are reflecting on our position. It triggers some very interesting conversations and requires also specific expertise on our side. This brings us to the conclusion of today's flagship conference. I hope you really enjoyed it. There is our statement, which really distills, I would say, the key messages that you heard today throughout the day from our thought leaders, from our presidents, director generals. This is an issue that obviously will remain a priority for ESIP and its members, the members that are financing this, designing these solutions, but also implementing these solutions and these interventions. And I hope you enjoyed the fact that you heard real hands-on experiences from the people who try to, day by day, to try to serve the millions of the insured. Thank you so very much. I want to thank Benedetta Baldini, my colleague, for her help. We couldn't have done it without her. Emily Weissman and Françoise de Blutz. We are a very small team at ESIP, but we're doing our best. Thank you so much for coming. The conversation continues. I refer you to our statement. And of course, as Ilka said at the very beginning, there's going to be another publication on our recommendations on the high-level group on the future, which is a broader discussion on the future of social protection in Europe. Thank you so very much. Thank you.